Welcome to Dr. Seven Medical Academy. I'm absolutely thrilled to have you here for this explainer. Today, we're exploring the mechanical breakdown of the lumbar spine that leads to some truly agonizing nerve compression. Now, whether you're a medical student prepping for your board exams and you need that high-density clinical precision, or you're just someone who wants a really intuitive visual understanding of how your own body works, this masterclass is for you. We're going to break down the anatomy block by block, look at exactly what goes wrong, and explore how modern medicine actually fixes it. Here's our roadmap for today's session. We'll start with the biomechanical blueprint, move into anatomical chaos, cover diagnostics, explore treatments, and finish up with a high-yield recap. Let's jump right into section 1, the biomechanical blueprint. Okay, let's start with a really simple analogy. Think of your spine as a stacked series of blocks, separated by dynamic shock absorbers. We call these the intervertebral discs. Think of them kind of like a jelly donut. You've got a tough, fibrous outer ring, the annulus fibrosus, and a soft, gel-like center called the nucleus pulposus. These discs are constantly under massive load. So why do these jelly donut-like discs specifically fail at the absolute lowest part of the lumbar region? Why is the L5 nerve root always in the crosshairs? Well, it actually comes down to mechanical vector stress during heavy lifting, combined with the fact that a key supporting ligament, the posterior longitudinal ligament, actually gets narrower as it travels down your lower back. That narrow ligament makes the disc super vulnerable to posterolateral herniations, where that jelly center just bursts right out the back. Now, compounding this issue is lumbar spinal stenosis. Stenosis simply means a narrowing of the vertebral foramen, which is the bony canal where your nerves travel. Sometimes this is a hereditary anomaly, meaning you're just born with less space in there. This makes a person highly vulnerable to age-related wear and tear. It's literally like a highway that's already missing a lane. Any small accident, like a tiny disc bulge, is going to cause a massive traffic jam. Moving right along to section 2, the anatomical chaos and compression. Looking at these clinical correlations drawn straight from Moore's clinically oriented anatomy, we can bridge the gap between perfectly drawn textbook anatomy and the beautiful, chaotic reality we actually see in patient imaging. It shows us just how incredibly tightly all these structural elements are packed together. There is basically zero room for error. And what's really interesting here is this cruel paradox of human anatomy. As you descend the lumbar spine towards the sacrum, your spinal nerves actually increase in size. They get noticeably thicker. But paradoxically, their exit pathways, the intervertebral foramina, actually decrease in size. So you've got larger nerves trying to squeeze through much smaller doors. This means the L5 nerve roots are the absolute thickest nerves in this region, desperately trying to fit through the narrowest holes. This dramatically spikes the risk of compression. If a patient develops osteophytes, bony spurs, or if they suffer that herniated disc we talked about, that L5 root has absolutely nowhere to hide. Now, for our board prep students, listen up. You need to lock in the rule of traversing versus exiting nerves. An L4/L5 posterolateral herniation hits the traversing L5 root, not the exiting L4 root. That causes weakness in big toe extension, specifically the extensor hallucis longus, leading to a classic foot drop, plus sensory loss on the top of the foot. But if it's an L5/S1 herniation, it hits the S1 root. That leads to a loss of the Achilles reflex, weakness in plantar flexion, meaning the gastrocnemius muscle, and sensory loss on the pinky toe. Section 3, clinical diagnostics and imaging. So, when a patient comes in with this kind of agonizing pain, how do we act as medical detectives? Well, first, we do physical exam maneuvers. A classic one is the straight leg raise, or Laseg test. We physically stretch the sciatic nerve right over that herniated mass. If it reproduces their pain, we know we're on the right track. Then we turn to specialized imaging. Today, magnetic resonance imaging, or MRI, is heavily utilized for mapping spinal structures without using radiation. But we also have a highly specific old-school tool called myelography. Unlike a standard MRI, myelography is a radio-opaque contrast procedure that gives us an incredibly sharp, direct visualization of the spinal cord and roots. Let's look at how this builds. In myelography, physicians perform a lumbar puncture to carefully withdraw a small amount of cerebral spinal fluid. They then replace it with a radio-opaque contrast material. Think of it like dropping bright, glowing dye into a stream so you can clearly see the outline of the rocks that are blocking the water flow. This perfectly illuminates those compressed roots on an X-ray, showing exactly where a disc or bone spur is intruding.
Section 4, Conservative Cures versus Surgical Procedures.
Okay, once we've pinpointed the stenosis or herniation, what do? Well, we objectively evaluate non-invasive conservative treatments first, which actually have an 80 to 90% success rate. The body has a truly remarkable ability to heal itself through something called macrophage-mediated enzymatic resorption. Basically, your immune cells literally eat the extruded jelly from the herniated disc. We support this amazing natural process with NSAIDs, lumbar stabilization, and targeted physical therapy like McKenzie extension exercises. We also use epidural steroid injections, where corticosteroid microdeposits are placed right next to the nerve to massively reduce local edema and inflammation. By doing this, we can often relieve that mechanical pressure without ever making a surgical incision.
However, sometimes conservative routes just fail. And more importantly, sometimes we see the ultimate red flag, cauda equina syndrome. If a patient presents with saddle anesthesia, bilateral leg weakness, or bowel and bladder dysfunction, that is an absolute surgical emergency demanding immediate decompression within 24 to 48 hours. When surgeons do escalate to active interventions, they might perform a decompressive laminectomy to physically remove bone and widen that highway. For a specific disc protrusion, they'll utilize a microdiscectomy, a highly targeted, minimally invasive procedure where they retract the nerve root and excise just the tiny herniated fragment. And if there's major instability, they might even do a lumbar fusion using screws and interbody cages to completely stabilize that spinal segment.
Finally, Section 5, the high-yield board recap.
For our medical students, it's time to lock in the high-yield facts. Master this rapid-fire matrix. Lumbar stenosis limits the canal space. At the L5 level, the thickest roots meet the narrowest foramina. And remember the clinical consequences. An L4/L5 herniation hits the traversing L5 root, causing big toe weakness and foot drop. An L5/S1 herniation hits the S1 root, costing you your Achilles reflex and plantar flexion. To see the impingement clearly, we use myelography or an MRI to visualize the exact point of compression.
This brilliantly illustrates our core takeaway, summarized perfectly by Moore's anatomy. Adding a bulging, herniated disc to a naturally narrow stenotic canal isn't just bad luck, it is a biomechanical recipe for absolute neurological failure. I want to leave you with this final thought to apply in your own practice or your own life. Knowing that the absolute biggest nerves are forced through the tiniest, tightest spaces in the lower back, the next time a patient presents with severe sciatica, how will this biomechanical blueprint guide your next steps? Because understanding the structure is always the very first step to mastering the cure. Thank you so much for joining me in this explainer, and keep learning.